So I'm just going to hit some highlights about where we've been in terms of cancer control at NCI and in the division, and some of the challenges moving forward. Next slide. So I'm going to talk a little bit about the launch of the division and some of the major programs and mechanisms for funding research that we've utilized in the division, and then again just touch on a few issues of current challenges and also mention our transition to our new division director who has already started. Next slide. So this slide, again, very selectively just highlights a few of the major events in the history of the Division of Cancer Control and Population Sciences, which I should say was formed, the division was formed in response to board criticism of NCI. So when Rick Klausner was NCI director, he commissioned 5 program review groups. And there was the Bishop Calabrese report, some of you are aware, which led to a major reorganization of NCI. So what I oftentimes call the brand reorganization under Rick Klausner, which really reshaped the NCI in a number of ways. And also at the same time, the Office of Cancer Survivorship was created. So I wanted to shout out for the Office of Cancer Survivorship because we're celebrating the 25th anniversary of OCS, which is very capably led by Dr. Emily Tonorezos. But again, the result of advocacy and input from advisors and engagement from the White House, again, in part related to the National Cancer Act. Barbara Reimer is the giant whose shoulders I've stood on as division director these last many years. She was appointed by Rick as the original division director of DCCPS. And she had the charge of literally sitting down with Bob Hyatt, the deputy originally, and myself, and with a blank sheet of paper, creating an entirely new division at NCI. So it was a really exciting time and a huge opportunity and a huge responsibility. We then formed a number of new programs and continued to evolve over the years in creating new branches, a whole new program a few years ago in healthcare delivery research, which at the time was a bit controversial, but also some signature research programs. So there's no way I'll go through all the RFAs and special initiatives. Instead, what I'm going to do is we will mail you our division's last annual report under my tenure, and so you'll be getting in the mail, and not in too distant future, a hard copy of our last annual report, which also includes a bit of a retrospective review on the major initiatives over the years. Next slide. One of the strategies we use in the division at the outset, which has become more common at NCI now, but was new at the time, was centers of excellence as a research funding mechanism to provide really ambitious research goals in a really complex, challenging area of great importance to cancer control. The first of these being the Transdisciplinary Tobacco Use Research Centers Initiative, which, like a lot of our centers of excellence initiatives that we've done in the division, was collaborative with other institutes and funders, in that case, NIDA and Robert Wood Johnson Foundation. But these centers of excellence initiatives, again, are only one subset, but they are the largest RFAs that we launched over the years, all of which were discussed and reviewed by the BSA, of course. But also, I think this is one way to kind of simply highlight some of the highest research priorities that we've had over these last several years in cancer control. We were the first institute at NIH to really put an effort in communication research. And that's really come back around to the NIH. And I think NIH clearly has recognized that the agency as a whole could have and should have made a broader commitment than just NCI, as we've seen in COVID and in the issues of vaccine hesitancy. We're fighting a war of misinformation, and I'm not sure we're winning that war. And so hopefully moving forward, a greater effort on health communication and understanding persuasion and how to counter misinformation about health and cancer as well. Next slide. So what's next in terms of these Centers of Excellence initiatives? one that the BSA, your group, recently reviewed. For those of you veteran members will recall, we just recently had the review for the new Centers of Excellence in Telehealth Research and Cancer-Related Care. So again, I think NCI is playing a really signature leadership role at the agency at NIH in telehealth. We really were tracking policy and developments over the last many years and saw the greater interest in Congress and also how telehealth became so vital during COVID. And I think it's really exciting that in the spring of next year, we will be deciding on and funding our first research centers on telehealth. And this will really be critical moving forward. Next slide. One of the things we've been careful to do, and this came up in the discussion on the moonshot and in Dina Singer's presentation, she, in the case of the moonshot, as you heard, but also all of us who've led major initiatives have been really mindful about evaluation and lessons learned. And our evaluation methods have been improving over the years too. So the science of program evaluation of initiatives in NIH has become more rigorous and more extensive and more validated, which is really important. And this, in our Centers of Excellence initiatives, we've really put an effort throughout the years in understanding how to improve the functioning of team science and team science projects. And so we actually ended up creating an entirely new field, now known as the science of team science. And the National Academies of Science have been involved with us throughout in this effort, and recently published a book on the topic that summarizes empirical evidence, research, studying teams and what makes effective teams. So I think this issue of evaluation is going to be important going forward. Next slide. You can't talk about cancer control ever in any context without talking about tobacco control. And it's still the case that cancer control's most important challenge is tobacco control. We probably don't discuss it enough. It's still the leading cause of preventable death in the United States and a leading cause of cancer death. And so obviously tobacco control has been an area of emphasis during my tenure as Director of Cancer Control at NCI, but will continue to be really important. So oftentimes we take it for granted, it's off the radar, but because it's still widespread and because it's still a challenge. Next slide. But I think one of the most remarkable public health stories of the last century is the progress we've made in tobacco control. And many of you have seen this slide before in various forms and over the years. But this shows tobacco consumption, cigarette consumption in adults in the US over the last many years, and its association with a number of signature scientific and policy events, all of which were very hard fought and hard won. I'm really thrilled that Dr. Hatsukami has joined our boards because this continues to be a huge challenge. And I'll come back to this a little bit more later in terms of future challenges. But I think it's really important as we celebrate the National Cancer Act to note that one of our biggest areas of progress against cancer is a result of our progress in reducing tobacco use. Next slide. And this is just part of the payoff. So oftentimes we talked about the reduction in lung cancer mortality. Again, reduction in tobacco use has been the major driver of this. More recently, fortunately, improvements in survival as a result of advancements in therapy, which have been incredibly remarkable. But also it's important to say that it's not just a cancer issue. Many, many different chronic diseases associated with tobacco use. So that's why for us, it's been a very collaborative interagency effort. FDA has played a key role, other NIH institutes like NHLBI and NIDA, the Department of Health and Human Services, but many other agencies of the federal government as well. And I got to give a shout out to the CDC. Our colleagues at the CDC Office on Smoking and Health have been very close, tight collaborators over the years, and they've done remarkable work at the CDC. Next slide. Key challenges moving forward. Again, this is very superficial, quick, simplistic, but moving forward in generating the evidence the FDA needs to exercise its regulatory authority. So there are many authorities, and we've worked closely with the FDA these last several years, and we've been the beneficiary, and many of you have been the beneficiary of FDA's funds, because it's been unprecedented the amount of money that FDA has transferred over to NIH from the FDA Center for Tobacco Products that fund many of our grants. So there's been a significant inflow of research funds not paid for by NCI, but by the FDA, and that's really important to acknowledge. But one of the authorities that they have is to reduce nicotine levels in tobacco products. And this is a really critical issue moving forward. And for them to exercise that authority, our research community needs to provide the appropriate evidence. Improving efficacy of quitting smoking. We focused on adults when it comes to quitting smoking, but we really need to improve the evidence base for getting people to quit sooner. Youth, teenagers, people become dependent very rapidly on nicotine, and we need more early intervention on cessation. Low SES populations, cigarette use in the US today is largely a risk behavior that's in the less educated and in underserved populations. And then, of course, the debate surrounding electronic cigarettes is still ongoing. Next slide. I wanted to point out this in terms of future challenges. There's a lot of discussion on this topic, and that is obesity. But I think I wanted to point to this one particular paper recently published by our colleagues at the University of North Carolina that highlights that when you look at overall cancer trends of these last several years, a lot of the mortality reduction in cancers over the last several years have been in the non-obesity associated cancers. If you look at the subset of cancers for which obesity is a risk factor, you don't see the same rate of progress of mortality reduction. And this is a really troubling sign because these mortality rates are the report card in the war on cancer. They change slowly. They're influenced over many, many years. And so this is a red flag for all of us moving forward, the threat of obesity and challenging our progress against cancer. Next slide. One of the areas of my own focus and Director of Cancer Control these last years at NCI is really building up and enhancing the research infrastructure for population science in the US. And so I want to make a few remarks on that, the essential infrastructure of population science. Next slide. I could spend this whole talk just talking about epidemiology consortia. Bob Hyatt and Bob Hoover several years ago at NCI were the visionaries in the formation of many of these consortia. We have many of these consortia now, but they've been a model of collaboration, of data sharing, and of enabling and providing the statistical power for molecular epidemiology and understanding gene-environment interaction and risk factors. So again, I won't go into this in detail. We could come back to this, but two of the program announcements you'll be hearing about this afternoon relate to the epidemiology cohorts, which have been an essential infrastructure and will be on an ongoing basis for cancer research. Next slide. Cancer surveillance, we've made remarkable progress, and Lynn Penberthy presented to the boards a few meetings ago some updates on this. Next slide. So I'll just mention this briefly, but one of my own goals as Director of Cancer Control was that by the 50th anniversary of the National Cancer Act, we would expand the SEER program to cover 50% of the entire US population. And we've just barely made it. We reached that goal this year. And that's really important, not just from a program perspective, but from a scientific perspective. From the scientific questions we are now enabled to address and pursue, particularly with ethnic minority populations and subpopulations. So this is the current map of SEER, and we changed SEER because we now have two tiers of SEER contracts, both the traditional research, full research support contracts, and then smaller contracts to support research entities. These are the light blue regions on the map. These are very small contracts, but that put in place a mechanism that then enable these sites to participate in special research projects with the entire SEER system. And also I have to give a shout out to the CDC, National Program of Cancer Registries, who've been a great collaborator of ours, and especially their participation with us in the new Childhood Cancer Registry initiative has been really essential. If you notice this map, some of the states that have been added really diversify who's enrolled in SEER, who's registered in SEER. For example, the state of Texas. Let me go to the next slide. And this summarizes what's been discussed at previous board meetings, so I won't go through this, but many of the other reasons, scientific reasons, why expanding SEER is so important. Next slide. This is one. And I think continues to be underappreciated by policymakers, by scientists, even by our academic community, and the significant demographic change happening in the United States today. And this example of the percent growth of the US Latino population really deserves more attention from the scientific community. We are lagging behind in terms of generating the subpopulation relevant evidence, not only for the Latino population as a whole, but for the complex many subpopulations where you see genomic stratification and the complexities of understanding the genetic epidemiology, not only the impacts of exposures in these subpopulations. Next slide. So this shows the progress we've made in filling in these gaps. And this is going to be a critical platform for health disparities research moving forward. If you look on the bottom right, for example, we've really expanded the Hispanic enrollment in the cancer registries. Also in the Asian population, the diversity of Asian subpopulations represented in SEER has undergone a significant change. So this is new. This new expanded research infrastructure is just being built and expanded over the next year, but this is going to be an enabler for population science research and clinical and basic science research moving forward. Next slide. Surveillance is just not about cancer incidence surveillance. So our surveillance program goes well beyond cancer incidence. For example, we lead or co-sponsor many national surveys. These are critical components of surveillance, as we've seen during the COVID epidemic. One example is the Health Information National Trends Survey. We monitor at a national level what the public thinks and knows and their myths about cancer. And this is really essential information as we monitor and develop strategies for cancer control intervention and communicate with the public. Next slide. One of my own priorities during my tenure, and some people have accused me of bias, I'll have to say, because I come from two cancer centers, previously working at Huntsman Cancer Institute and Fred Hutchinson Cancer Research Center, is several of our initiatives that really focus on leveraging cancer centers more extensively for population science research, but also for cancer control and community engagement. So I want to spend a few minutes just on that issue. Next slide. One of the things that I chose to do with our discretionary budget in the division is to really focus on the utilization of cancer center supplements as a mechanism to catalyze new areas of research. And I believe that this has been really successful through very small supplement awards. Oftentimes these are $100,000, very small P30 supplements. I believe they've had a transformative impact on growing a number of areas of critical population science and cancer control research. This slide shows all the topic areas where we've done cancer center supplement initiatives. And so these are all described in much greater detail on our website, and you can go there and get a lot more information about these. So I'm just going to mention a couple of these, but I've observed that they've really energized ramp up of work and effort at cancer centers in these domains. Next slide. One example of 3 supplements that were purposely timed to coincide with our implementation of the community outreach and engagement requirement in the cancer centers, which I also believe had a transformative impact on cancer center mission and impact, is one on HPV vaccination. So we did 3 rounds of supplements, for example, but this also led to a lot of more collaboration in national consortia, and also generated pilot work that led to a number of new grant awards and greatly expanded our research portfolio related to HPV-related cancers. Next slide. These are just some examples of things that grew out of these supplements, including the first ever national statement co-signed by every NCI Cancer Center director concerning the importance of HPV vaccination. So the impact on programs and policy at the state and local level can't be underestimated. And that's one reason why Henry and I felt that adding that language on community outreach and engagement to the CCSGA guidelines was really critical, because our cancer centers are stepping up in new ways in terms of impact on their local communities in a way that's never happened before. Next slide. Another example that Dina talked a little bit about in her summary of the Cancer Moonshot was the C3I initiative. This was a unique cancer center supplement initiative among the ones that are division led because it was entirely funded by the Cancer Moonshot. So it's larger in scale, much larger in scale in terms of number of awards than any of our other supplement initiatives, but addressing a huge recalcitrant problem, which I think was a chronic embarrassment to the NCI and the cancer community. And that is the fact that until recently, many of our cancer centers were not assessing or providing cessation services to all their cancer patients. And so it was a classic ambitious cancer moonshot initiative. And I have to give shout outs again to the boards, our advisory boards, for catalyzing this. It was really Karen Emmons and Graham Colditz when they were serving on our advisory boards who bent Doug Lowy's ear, who was acting director at the time, saying, hey, if you want a moonshot, how about making sure that all the smokers with cancer that we're treating get cessation services? Hello. So this has been a remarkable initiative, but one I have to say that I'm concerned about because the moonshot funding has ended. Now the ball sits with the cancer centers, and it's up to our cancer center directors community to sustain these clinical services that were first piloted through research funds. Next slide. This shows you just one measure of the impact of this supplement initiative. Over 63,000 cancer patients reached by C3I programs. I think a real remarkable accomplishment of all the centers who participated in this Moonshot initiative. So things are changing, folks, but we still have a ways to go because now we need to institutionalize these in the clinical service lines of every NCI designated cancer center. Next slide. And this again highlights the fact that in this last year, we have provided funding to the University of Wisconsin, the Coordinating Center. They have 1 year of funding left to assemble, aggregate, and disseminate all these lessons learned. And they're going to be providing tools and toolkits for every cancer center, not just NCI designated, but for every cancer center, excuse me, in the nation to implement similar programs. Next slide. And here's one that maybe you weren't expecting, but one of a couple of topics I'm going to leave you with before we go to discussion. You know, I'm a couple of weeks away from retiring from NIH, but if I were to say that what's the big hanging chad of the NIH in public health relevant to cancer, it's the fact that we are doing way, way, way too little in the science of understanding cannabis. Its health impacts, not only in youth, but its impact in cancer patients. And so I'm going to leave you with a little bit of a pitch here and tell you how we've just kind of getting started in this area and ramping up, but proselytize a little bit because I think we are undergoing a massive uncontrolled health experiment in the United States of America with a change in cannabis policies across the US. And we hardly have a clue about the health impact of what we're doing. Next slide. This is changed again in these last fall elections in some states, but just showing you the massive policy change that the nation has undergone that many of you are aware of in terms of access to cannabis, not only medical, but broad public use, recreational use. And a lot of state legislatures, frankly, have been frustrated with us, with NIH, because every time a state legislature debates these policy issues, they say, well, show us the evidence. What does NIH have to say? And we oftentimes have to kind of shrug our shoulders and say, well, it's a work in progress. There's a lot we don't know. So we are not doing our duty in informing policymakers about understanding the impact of cannabis use. Next slide. This illustrates it from a public health perspective. This is from the Monitoring the Future study that NIDA runs, a really important surveillance study where they survey 12th graders across the US. Look at the progress we've made in terms of reduction of cigarette use among 12th graders, a remarkable accomplishment over the last many years. But cannabis use is now double cigarette use in high school seniors. Think of the wealth of evidence we have gathered about tobacco use, tobacco control in the United States, and all the agencies with programs focused on tobacco control, and marijuana use in seniors is double that of tobacco use. Next slide. And if you look at vaping, radical increases in vaping. You've all heard about vaping and cigarettes and e-cigarettes and Juul, right? The Juul epidemic. Well, vaping is also a huge phenomenon among our youth in cannabis use and combinations of tobacco and cannabis and all kinds of crazy combinations of products that we know very, very little about. Next slide. So we've did a cancer center supplement last year. Again, kind of pushing the envelope, nudging our research community. And one of the reasons I've done these supplements, frankly, is to grab all the cancer center directors at once and say, hey, pay attention to this, because this is something that also we may consider for future NCI funding. That's one reason people pay attention to these supplements, right? Gee, maybe there's going to be an RFA later. And oftentimes that's been the case. So, but it's also trying to increase attention in our research community to an issue. And so we awarded 12 cancer center supplements just to focus on one subset issue, and that is cannabis use among cancer patients. And so 12 cancer centers have been gathering data on cannabis use among cancer patients. And in the next few months, we're going to get a whole new wave of data. I've seen some of the data, much of it's not published. So take this with a grain of salt. But in general, I think we can say that roughly, based on studies that have been completed so far, as many as 20-25% of all of our cancer patients in the nation, we think, may be using cannabis. That is a massive uncontrolled exposure for our cancer patients. And again, we need to understand this a lot better. Next slide. So NCI held its first cannabis workshop. Some of you participated in that. We funded the supplements, again, to try to draw attention to this area and catalyze planning and research teams. We are discussing the possibility of some type of concept in the future, but that's up to my successor, Katrina Goddard. that's as I step down. And we're really working closely with other agencies at NIH and HHS on this issue, because our surveillance of marijuana use, for example, is very poor because it's really hard to get good, accurate self-report data. You ask people what products they're using, what's the THC content, half the time they don't know. Use is sporadic. I don't use anything in the week, but I do on weekends. The products are complex, really tough problem epidemiologically. Next slide. What's the greatest challenge? Well, now that I'm leaving NIH, I can talk about policy. The greatest challenge is DEA scheduling. Marijuana is a Schedule I drug under DEA policy provisions, equivalent to heroin and ecstasy. I mean, it's absolutely insane. And this is a huge barrier to research and a barrier to NIH being able to fund the research. So this is being debated in Congress. All the attempts to open this up legally through the court system have failed. So it's up to Congress. There are rescheduling bills in Congress. Very recently, Senator Schumer came out and said that he supported descheduling, which I think is really important for opening up opportunities for our investigators. Our investigators are incredibly constrained. Next slide. I was finished saying a few words about health disparities. Again, we could spend a whole day on this. But one of the things I'm really proud of in my tenure as DCC's director is the significant expansion of our research portfolio in health disparities. And the fact that the health disparities research we are now funding is absolutely high quality, state of the art. And we're in third generation health disparities research, funding studies that are really looking at complexity and the interaction of biological, environmental, behavioral, socioeconomic factors in a sophisticated way that really, really is remarkable and is going to inform us going forward. Next slide. we have our own coding system for grants in the division. So this is not official. This is not official what NIH says or NCI says. When Sonia pulls together these data, she has to follow the rules that NIH has for how you code this stuff, which are not the greatest coding system, I'll have to say. And I'm leaving so I can say that. So Sonia has had to suffer under this antiquated coding system. We do additional coding of our grants, much more specific, much more focused on research aims. And I'm proud to say that in the last 4 years, our health disparities research portfolio, that is asking health disparities research questions, has doubled. And part of that is that not just RFAs and special initiatives, a lot of it is that the applications are scoring better in peer review. And that's a really shout out to all the training programs. You know, CRCHD has invested a lot of NCI money in our investigator training programs over the years, but also the fact that we've grown the entire investigator base, not just minority investigators, but those conducting research in this domain. Next slide. So some of the big opportunities going forward and gaps in our disparities portfolio, we have a tiny portfolio focused on American Indian Alaska Natives. And this is a subpopulation where the cancer burden is tremendous. And it's very difficult, very complex, lots of cultural issues and tribal governance issues. These are independent entities that have a special relationship with the US government. So the policy issues are complex. The history is not pretty. And trust is a huge issue in these communities. I've got to give a shout out to Shobha Srinivasan and our own group, who's devoted the last several years to outreach and collaboration with these communities. But hopefully you'll be hearing more about this in the future. Sexual gender minorities, again, SGM research, a very small part of our portfolio. And I think the time has come to really rejigger how we do cancer control in the United States and to really target all of our efforts, research efforts, public health program efforts, more specifically targeted. So just like our molecular targeting strategy for cancer therapeutics, we need more specific targeting to those populations in the greatest need. And oftentimes they're the populations who are not participating in many of our research studies. You'll be hearing more about this in the last agenda item for today, when Shobha presents kind of the last major RFA under my tenure, focusing on persistent poverty, looking at the whole problem in a very different way. Next slide. Some of the challenges moving forward, I won't go through all these. Ned mentioned several of these, but I think an opportunity to revisit our entire relationship under Karen Knudsen's leadership of the American Cancer Society. Now's the time to do it. It's great that Karen has taken on that role. You've heard about breast cancer in the environment and our stronger relationship with NIEHS. Really important. A lot of huge issues in epidemiology, as Ned mentioned, and environmental toxicology. We're really struggling in that area. We need to grow our research portfolio. The GDPR, that's the General Data Protection Regulation in Europe. This is huge, folks. Many of you know this because if you try to collaborate and share data with those in Europe, for the last 3 years, it's been incredibly difficult to share data, for example, in epidemiological studies with colleagues in Europe. We haven't figured this out. NIH is really struggling with this European Union policy on data sharing. Private sector big data, we barely touched the service in collaborating with the private sector on their massive commercial data sets, not genomics data sets I'm talking about or proteomics, but I'm talking about commercial data sets from marketing databases companies that know way more about you, every individual, than you can imagine. We have not leveraged that for population science research. And I also mentioned the future of cancer center community outreach and engagement. We need a new sustainable funding model for COE in the cancer community. Our centers cobbled together money from philanthropy, from supplements that we've awarded, et cetera. But maybe, now that I'm leaving, I could say maybe we should rethink our CCSG and whether or not there should be dedicated funding on COE. Next slide.
Bob, we want to make sure we have a couple of minutes for questions.
That's my last slide.
And comments.
Yeah, so this is just to say I think the future is bright because our leadership group of the division is terrific. We have a new director who's already started, Katrina Goddard. It's been a great transition. She'll be terrific, and they will benefit from your advice, just as I have. Thanks, John.